الفاضل في وحدة الأعصاب كلية الطب جامعة عين شمس على هذا النجاح الباهر لهذا المؤتمر المتميز دوما، وكل سنة ما شاء الله بيزداد تألقا وإبهارا وتميزا كما تعودنا. هي الوحدة العظيمة التي كلنا تعلمنا فيها ونشأنا فيها وترعرعنا فيها وما زلنا نتعلم منها الكثير والكثير. حفظ الله أساتذتها على مدى الدهر وزادهم علما وتوهجا وإبهارا كما تعود. الآن لي الشرف أن أنا أقدم أستاذ الفاضل أستاذ الدكتور عاصم عبد اللطيف، أستاذ جراحة مخ وأعصاب جامعة عين شمس، فليتفضل.
Assalamu alaikum. First, I would like to thank Professor Dr. Sahar Hassanain and the organizing committee for inviting me to this prestigious meeting. It's really a very nice idea to have a sort of a multidisciplinary approach for the assessment and management of one of the most common diseases with pediatric neurology and the pediatric neurosurgeons encounter. This is the pediatric hydrocephalus. It accounts or represents about 30% of the practice of pediatric neurosurgery, or I'm sorry, 30% of the practice of the whole neurosurgical operative load at Ain Shams University. And it's really very important to have a multifaceted understanding of the disease. A very smart idea to gather experts in the field of the pediatric neurology, the pediatric neuroimaging, and humbly myself to share ideas, to share perspectives, because honestly speaking, the practice at Ain Shams University and probably in the rest of Egypt is sort of dissociated, where each specialty are concerned and minded with their own perspective, and they're not sharing their ideas with colleagues. So we have conflicting ideas. Sometimes we argue, and I guess we will continue to argue for some time, but our gathering here helps to ameliorate the argument and also improve the sort of understanding and mutual benefit in favor for the patients. Hydrocephalus, to start with, I'm not talking about lecturing you about hydrocephalus, but just to give you an idea that even the definition of hydrocephalus was controversial, because we don't speak common language. You don't have the foundation for common understanding about which patient is considered hydrocephalus and which patient is considered ventriculomegaly. As Dr. Marwa has eloquently presented, patients with brain atrophy, hydrocephalus ex vacuo, these patients we argue about whether they need treatment or not, whether he is a symptomatic patient or not. But conventionally, or traditionally, we understand that hydrocephalus is a dilatation of the ventricular system with increase in the intraaxial CSF volume. And so we're concerned about the ICP, we're concerned about the etiology of the hydrocephalus and the anatomical topography, but sometimes we overlook the idea of the hydrocephalus ex vacuo and the brain atrophy, because in these cases, the dilatation of the ventricular system is on the expense of the brain mantle. So these patients we see often with post-irradiation, with post-infectious sequelae, they develop brain atrophy. Patients with repeated shunt malfunctions and obstruction, they develop brain atrophy, and sometimes they grow their ventricles, or their ventricles increase in size without having shunt obstruction. This is basically because there is a conflicting opinion about if this dilatation is due to the shunt malfunction or this dilatation is due to the brain atrophy and the subsequent ex vacuo dilatation. And here comes the MRI shuntogram that was presented earlier, that comes to differentiate these points if the shunt is functioning or not based on the imaging data. So to bypass this idea, another definition was proposed, which is the active distension of the ventricular system, which means that something is inflating it from inside, and this excludes the idea of the brain atrophy. But to give you an idea about how this has, even the definition of hydrocephalus has went through iterations and different reiterations, and even the pediatric neurosurgeons had to convene in a hydrocephalus International Hydrocephalus Workshop in Crete to come up with a definition to be endorsed by the International Society of Pediatric Neurosurgery, just to come up with something to serve the inclusion of external hydrocephalus into the definition of the hydrocephalus, because these patients with external hydrocephalus were overlooked. They were not treated for most of the time. They were, sometimes not considered as a subset of patients with hydrocephalus. So they included them in the definition in order to institute treatment for them. And one of the most common classic teaching paradigms is communicating versus obstructive. And this is a classic teaching as well. It also emphasizes the idea of the ventriculo-cisternal bulk flow, which means any obstruction to the bulk of the flow of CSF from the ventricular system to the cisternal space would definitely result in accumulation of CSF and subsequently an increase in the ventricular size and hydrocephalus. But this is emphasizing an issue of volume of the CSF. It's not, which is not a valid theory in some of the cases. We can see patients with post-irradiation sequelae, post-infectious sequelae who develop an increase in the ventricular size without an increase in the volume, actual increase in the volume of the CSF. So it could be related to an increase in the compliance of the ventricular system or a decrease in the elastic recoil of the surrounding brain tissue. And this is an issue, the pressure of CSF, which is to be emphasized in the future, or in the recent iterations of the classification of hydrocephalus, because it also relates to the systolic propulsion of blood into the cranial cavity with each cardiac cycle. And this is something that we are starting to take into account as a theory for the development of hydrocephalus in some patients. So it's no longer communicating versus obstructive, it's all obstructive. The question is, where is the site of the obstruction? And this is really important because it definitely relates to the proposed surgical management or the proposed treatment. We are starting to offer more endoscopic third ventriculostomy for patients with obstructive hydrocephalus. It's not all shunt for all patients anymore. And we are reserving the VP shunt for patients with obstruction or obstructive hydrocephalus, but outside of the ventricular system. Obstruction at the cisternal space, cisternal scarring with post-infectious hydro, or obstruction at the venous drainage or in the systemic circulation. And this is one of the diagnostic, the patients that we have diagnostic dilemmas or management dilemmas. This patient with external hydrocephalus may be asymptomatic, maybe incidentally diagnosed, or maybe presenting with simple forehead bossing and delay in the head support. Most of these patients will go without surgical intervention with conservative management, but some of them may require a shunt, which we would be very discouraged to put, but at some point, the clinical situation dictates it. Why are we discouraged? Because the ventricular dilatation, as you can see, is not that appreciated. But if these patients continue to develop, delay the milestones progressively, or progressive forehead bulging with a divergent microcephaly, then we would definitely shunt them in a ventricular, in the form of a VP shunt. And these two patients, they're not the same. This is a hydrocephalus ex vacuo, as you can see, as you can all diagnose, with brain atrophy and brain mental loss, subsequent negative dilatation of the ventricular system. But in this patient, he has sort of ventriculomegaly, which is asymptomatic. Another more challenging case are these patients that we meet in their early adulthood and late adolescence. They have big heads, they have chronic hydrocephalus, which was asymptomatic. And if we do a fundus exam, then it's normal, because a slowly progressive increase in the intracranial pressure would not result in a papilledema. And then these patients present with manifestations of chronic hydrocephalus in the form of cognitive decline, unsteady gait, and incontinence. These patients, if they have, with the imaging proven obstructive hydrocephalus, they would do greatly with endoscopic third ventriculostomy, and there are many case reports in literature highlighting this treatment. So shunt would still remain the standard treatment for hydrocephalus for most of the patients, but I'm just highlighting the less famous options that we may use in specific situations. A ventricular access device, as the My Reservoir or ventricular subgaleal shunt, as we see here, is something that we use definitely, and there should be a first option to be offered for patients with prematurity, very low birth weight, and suffering from a progressive post-hemorrhagic ventricular dilatation. Why do we offer this? Because of the risk of the necrotizing enterocolitis, the shunt exposure, and the shunt infection. If we plant a shunt or a regular ventriculoperitoneal shunt in a patient with a body weight of 1.5 kilograms or very thin skin, we need to have a temporary CSF access device where we can do shunt taps, or we can do, taps and CSF drainage intermittently. And then until the patient is old enough or the weight permits 2.5 kilograms at least, or a very acceptable skin turgor, to plant a ventricular peritoneal shunt. And there's a lot of retrospective review. The colleagues at St. Louis University, Matt Smith specifically, they found that there's no difference between the Omae reservoir or the ventriculo-subgaleal shunt. And even the fellows at Italy, Giuseppe Sanelli, he even went further and planted the Omae reservoir or the ventriculo-subgaleal shunt in patients with progressive post-hemorrhagic hydrocephalus, and waiting until they require definitive treatment, then offering endoscopic third ventriculostomy. And he came up with very good results, about 60% shunt independence in patients who were traditionally shunt-dependent population. These are very encouraging results. So we can do more endoscopic third ventriculostomy in patients with apparently communicating hydrocephalus or non-obstructive hydrocephalus. Recently, what is gaining popularity in our institution at Ain-Shams is the endoscopic ventricular lavage. It was introduced by William Whitlow at first in a multi-center RCT with 70 patients recruited for the drainage fibrinolytic therapy for progressive post-hemorrhagic hydrocephalus. Or progressive dilatation, progressive ventricular dilatation in a post-hemorrhagic sequelae. The first results, or the early results, were fairly the same, comparing the DRIFT trial to the standard treatment, which is repeated lumbar puncture or medical treatment. When they analyzed shunt dependence or death, they found that there was no significant difference. But really, on the long-term follow-up, they did elaborative work and finding very encouraging results about the improvement of the cognitive disability in these patients with who undergone the endoscopic lavage or the ventricular lavage. 66% of them, they had no cognitive disability, compared to the 35% in patients with the standard treatment who didn't receive the lavage. And so the DRIFT trial is the first intervention for the progressive post-hemorrhagic ventricular dilatation to objectively demonstrate sustained cognitive improvement. In this sense, doing more endoscopic lavage for patients with post-hemorrhagic hydrocephalus is really an important option to offer for these patients. Endoscopic third ventriculostomy, or ETV, is having growing popularity recently, and we really assess the likelihood or the suitability of the patients for ETV using this ETV success score offered by a landmark paper. The score, as we can see, takes into account variables as the age, etiology, and the presence of previous shunt. With the lowest score in the very young age, we cannot offer ETV competently for patients younger than 1 month with post-infectious hydrocephalus or had previous shunt, because the likelihood of success was close to 0, as you can see. But we are confident in offering ETV for patients who are older than 6 months with aqueduct stenosis or obstructive hydrocephalus, intraventricular obstructive hydrocephalus, and no previous shunt. Their likelihood of success is around 50 to 60% or even 70%. Doing the ETV, just as a quick thing, we do the endoscopy or the endoscopic approach through a frontal burr hole and go through the brain into the ventricles. And that's a patient with hydrocephalus. I want to show you inside. Yeah, that's the trajectory. That's the trajectory that we use for the endoscopic entry through the frontal horn. And then it gives us an access inside the ventricular system. That's the floor of the third ventricle, as we can see through the foramen of Monroe. We puncture the floor of the third ventricle and then widen the puncture using the Fogarty balloon catheter. Any membranes, as the Lilliquist membrane in the prepontine cistern that we can visualize, should be dissected completely to ensure a functioning endoscopic third ventriculostomy using combined action. So currently at the neurosurgery department at Ain-Shams University, we have two clinical studies going on. One of them is on the efficacy of the endoscopic lavage. We extrapolated the DRIFT trial to the use of the endoscopic lavage for post-infectious and the CSF infection. That's one thing. The other one is the implementation of a certain protocol for the management of the of hydrocephalus in infantile period using the endoscopic third ventriculostomy combined with a choroid plexus cauterization, because this is claimed to increase the success of the ETV by adding about 20 to 30% of success using the or attributed to the cauterization of the choroid plexus. Why did we do this? Because as Professor Dr. Sahar said earlier, that we found that the most common etiologies that we are dealing with are the Chiari type 2 associated hydrocephalus and the post-infectious hydrocephalus. I will go quickly, skim quickly through the study. I want to show, yes, here. We place the patient on the side and we plant the flexible scope. That's a scope that's around 3.5 millimeter in the 2.8 millimeters in diameter, and it goes inside this small skin opening and burr hole. The view is, I guess it's good and acceptable. We can go inside the ventricular system. The view, as you can see from the video, is the optics are less optimal or less clear than the compared to the solid lens as in the video that I previously showed. We can go very deep down to the prepontine cistern using the flexible scope because of the soft turgor and the small size of, or the small diameter of the scope itself. We can go in front of the basilar artery to see the dorsum celli, to even go close to the CP angle cistern and close to the foramen magnum to see the lower cranial nerves. So the ETV CPC currently, we have recruited around 50 patients. Success rates are ranging from 60 to 70%. Failure, in cases of failure of ETV, we can do another trial of a redo ETV, and that's really, to me, is a surprising change of concept, because early on, about 15 years ago, when we mentioned the use of ETV or endoscopic lavage, this concept was, or this thought was strongly discouraged because of the lack of advanced equipment, the suboptimal optics, and subsequently the high risk profile of the procedure in the early experience. But recently we are getting somewhere in terms of reviving few techniques, not introducing new techniques, but reviving techniques that fell out of favor with time. Thank you.
Thank you, sir, for this elegant presentation. Really, I learned from you, Dr. Assem, and I'm going to change my education policy for the undergraduates regarding hydrocephalus. Okay. Now, to finish